We've written some questions for after the session as well, and also we've basically tried to put together a few questions, some of which we think is really relevant for finals, and then some's maybe a little bit extra, but essentially just try and highlight the key points, because upper GI is quite a big topic. So really what we want you to come out from today is that you're just a little bit more confident with, you know, the key topics, because you don't have to go and learn everything. So I think Mike's going to share first, and then we'll just go from there. But there's lots of questions, like polls that we'll put up. So if you could just respond to them. And yeah, that's about it. And then Mike.
Yep, sounds good. So I'll just pull it up now. Right. Can you guys see the slides?
Yeah.
Cool. And is that all okay for you guys?
Yep.
Cool. So as Oscar kind of alluded to, I'm Mike. I'm a 5th year intercalating medical student. And I'll save Oscar the repetition. Oscar is also a 5th year. We have the pleasure of being good friends. And we've chucked together some slides on upper GI content effectively. And we're hoping to cover what we think is the most important stuff. So I'll walk through some esophageal gastric work. So that's, as it sounds, up to basically esophagus and the stomach. Oscar will then go a little bit further downstream. I know we have a few people in the chat. If you want to ask questions, go free, go wild, feel free. Oscar will be on hand when I'm talking to answer anything, and if we want to stop, we can and have a chat, and then vice versa when we swap over in a little bit. Okay, so as I said, these are the topics. Little reminder, don't forget about gallstones. I'm sure peer medics will do a talk that discusses them, but they're not particularly relevant to what we're talking about at the moment. So we'll start with a case. So this is a case of a patient who presents with heartburn. We've got a Mr. Edgington who's 56 years old, who presents with upper abdo pain and discomfort. Describes a 3-month history of epigastric burning discomfort associated with belching, a dry cough, and the accumulation of saliva in the mouth. They have a past medical history of type 2 diabetes and hypertension, on the following medications, and struggling to adopt new lifestyle measures to help with his diseases. We've got a smoking history and an alcohol history as presented, and he mentions that he's lost a little bit of weight recently, unsure whether that's due to his diet, dietary changes, or the pain or the discomfort. So I just want you to try and have a little moment's thought of what you think, what you're thinking about when you see this presented. And further, we're going to think about how we want to manage this patient. So we've obviously jumped a step. You might want to be thinking about what you think your most likely diagnosis is. But one step further than that, out of the 5 options, excuse me, I'd like you to let me know what you think you would do in this situation. So Oscar's very kindly popped a poll up on the screen. We'll give it 30 or so seconds. And just for the sake of clarity, everything's anonymized on the poll. So if nothing else, give it a shot. There's no way of telling who's answered what. Okay, a few more seconds. We've got a fair few votes in, still a few to come. Cool. So we've got a split. So the split is between B and E, with 40% of the votes each. Then we have a couple people that went for A and a couple for C. So this is quite a tricky question, and there are a couple levels to it. Fundamentally, we might be thinking about a diagnosis, which is what some of you guys might have been thinking about. And to me, I think we could argue that it sounds like a sort of reflux gastritis sounding picture. And so the people that talk about lifestyle management, that's definitely helpful in those diseases, as is antacids, as are PPIs and ranitidine. No one opted for D, which is good or reassuring, because there's nothing to say that this patient has H. pylori. You'd need to do your investigations. Now, the slight trick is that the answer actually is E. So what we're trying to get at here is this patient, you might see them in a GP setting and you might not even sound particularly worried about them on the most superficial of levels. However, you have to be aware of your 2-week wait criteria. So this patient hits a 2-week wait on the grounds that they are aged over 55 with abdominal pain and reflux symptoms, and they have weight loss. As you can see here, we've summarized the 2-week wait criteria for upper GI cancers. The things in black are your absolute concrete referrals under the 2-week wait pathway. The things in blue are described as consideration points. So I think in terms of exam revision, the highest yield work is the stuff seen in black. If you ever have someone that presents and meets these conditions, no matter what you think the most likely differential is, you need to be aware that they need to be sent under this pathway. The stuff in blue is, as I said, a little bit extra, and it's less prescriptive. It doesn't tell you black or white whether you need to send them down one path or another. So I hope that makes sense. So in this case, this patient actually meets the criteria for a possible gastric or esophageal cancer. And so what they would then undergo an endoscopic procedure, so an OGD. Okay. So question 2, we're talking about dyspepsia, and in the setting of the last question, we just talked about lansoprazole. What is the mechanism of action of lansoprazole? And there's no F on the poll because F's not right.
Why did you put F?
I felt like it needed a bit of spice.
All right. Sorry, I could have put F. I just didn't realize there was more.
That's okay. We've got plenty to talk about without an F in the picture. So last couple votes coming in. Cool. So we've got in ascending popularity, basically B through E. So B got a few, C got a few more, D got a few more, and E got the most votes. So the answer is E. So lansoprazole is known as a proton pump inhibitor. So it acts by irreversibly binding to the proton pumps in the stomach, and therefore it inhibits gastric acid secretion via that H+ ion secretion. And so option E is the best answer because it talks about that H+ pump, which is the H+ potassium ATP, ATPase. F was a bit of a red herring. Thankfully, we gave you the heads up that it wasn't F. So that F, the differentiation between E and F is to decide which H+ pump is the one it acts on. H1 receptor antagonists are useful in treating people's allergies and allergy-mediated reactions. H2 is used in dyspepsia, and then an example of that is ranitidine. And your COX inhibitors are anti-inflammatory in nature, and they're your NSAIDs most typically. So the correct answer for a proton pump inhibitor, of which lansoprazole is an example, is E, which is on the proton potassium pump. So a few summary slides then. So when we're thinking about GORD, GORD is a condition caused by prolonged contact between the gastric acid and the contents of the stomach with the soft lining in the esophagus. Now, there are a number of predisposing factors to GORD. And I think if you actually think about it in its most simplest form, you'll be able to remember a lot of these just by applying basic principles. So GORD is predisposed to by anything that effectively increases the intra-abdominal pressure. And so that's anything that puts weight on your stomach, so pregnancy or being overweight, or having a mass within the abdomen. And it also includes things that push upwards, such as a hiatus hernia. The other key part of GORD is the fact that patients often have poor dietary habits. So that might be with rich and spicy foods. It might be excessive alcohol consumption, and really basic things, again, like eating before bed or lying down after food, all predisposed to that splashing of the contents up into the esophagus. Patients often present, as this patient did, with dyspepsia, so epigastric kind of burning pain, with belching, a dry cough. Water brash is the accumulation of saliva in the mouth, and acid brash is that regurgitation of acid into the mouth, all of which the patient can often describe themselves. And it's actually a clinical diagnosis. It is possible, however, to undergo pH testing. And so some patients can have a little probe that dips down into the esophagus that measures the pH over a 24-hour period. But that's not necessary for a number of patients. And it's worth just reminding ourselves that patients with dyspepsia may well meet a two-week wait criteria. And so you need to remind yourself of that. So the management is fairly simple. I've tried to organize my thoughts as best I can into how I would answer this. I think it's quite nice to build up from the bottom. So starting with conservative measures, anything that reduces that intra-abdominal pressure may relieve the symptoms, i.e. weight loss. And it might be worth noting that in a patient who gets new GORD at pregnancy, it might actually ease off once their bump goes down after giving birth. Smoking cessation and alcohol is always a big part of management. And then dietary changes such as small regular meals, sitting upright after food, not eating before bed is all really helpful. In terms of your medical approach, you can have antacids, which are your sort of liquids that neutralize the acids directly. And you also have alginates, which are a little bit like rafts that sit on the top of the gastric fluid. They're kind of a jelly layer that stops things splashing up. And then you've got medications such as a PPI, which is your first choice, of which lansoprazole is a commonly used example. And then you can also use H2 receptor antagonists like ranitidine. And just for a bit of extra knowledge, laparoscopic Nissen fundoplication is a procedure where you basically overlap the bottom of the stomach with the esophagus, sorry, the top of the stomach with the bottom of the esophagus, just to provide some extra support. So we're talking about dyspepsia. A good differential then is gastritis. So there are a number of causes to be aware of, and they often overlap quite a bit. So you can have H. pylori gastritis, which is a commonly referred to condition in exams. You also have autoimmune gastritis, alcohol-related and smoking associated, and then medication is also a really big part as well. So just be aware of your causes and what you might be thinking about in terms of investigating and managing these patients. When we're talking about H. pylori, there are two main techniques we can use to test for. You can use the urea breath test, where you use radiolabeled markers which is then taken up by the bugs for their metabolism, and then it's exhaled on the breath. And then you have stool antigen testing, which is the probably more common and certainly easier of the two. And it's worth just being aware that these investigations are useful in the diagnosis of this condition. However, when you treat them, you have to use the urea breath test to test for eradication. So to check your treatment successful, it has to be urea breath testing and not H. pylori, and not stool antigen testing. So managing these patients is very much with consideration of the cause. If it's H. pylori, you need to treat them with triple therapy. So that's with 2 antibiotics and 1 PPI. Typically discussed would be lansoprazole with amoxicillin and clarithromycin. However, you will see other combinations mentioned. If it's an autoimmune gastritis, you'll need some degree of immunosuppression, which might be with steroids. And then, as always, you want to optimize their lifestyle and their symptoms. So moving on then, which one of the following is not associated with dyspepsia? Just a couple more seconds. Great. So E was the most popular answer. We have a couple votes for B and D. So E is the correct answer. Beta blockers aren't associated with gastritis or dyspepsia. H. pylori is a given. We've just talked about how you would treat that. We've also talked about overuse or overconsumption of alcohol being common as well, as are NSAIDs. So NSAIDs are a really classical example of a cause of dyspepsia, as are steroids, and that leaves you with beta blockers. So it's a little bit of a mean but quite straightforward question. In a couple months' time, it's just pattern recognition, seeing which ones you feel most comfortable with. So moving on then. So we've talked about patients with an epigastric abdominal pain and a classic kind of burning sensation. We're thinking of GORD, we're thinking of gastritis. Now we're thinking of epigastric pain. It may be a burning sensation, it may be more severe. And so one differential to think about is peptic ulcer disease. So an ulcer is just very kind of basically a break in the lining of the mucosa in a region of the gastrointestinal tract. And it's often in an acid-bearing region. And there are two types of ulcers to be aware of. So you need to be able to be aware of the risk of a duodenal and a gastric ulcer. And in the boxes presented are a couple ways to differentiate the two. In practice, you probably wouldn't do this clinically. You'd need to investigate them, you'd probably scope them, and then you'd make you'd note your findings. However, in an exam question, it's not always that kind. And so you need to be aware of what you're looking for effectively. So duodenal ulcers are the most common. They're often seen in younger patients, and they really strongly are associated with H. pylori. And the most classical way to differentiate the two are based on the symptoms. So duodenal ulcers symptoms are often worse at night, and they're often relieved with food and with antacids. So that's worth just bearing in mind. And when you think about worse at night, that kind of makes sense because much later down the line after you've eaten your meal, the food's then going past the ulcer and irritating it, not in the immediate phase when eating or very, very soon after. Alternatively, you have gastric ulcers, which are the less common of the two. They're often seen in elderly patients. And although they are associated with the same risk factors, they're less so. Symptoms are worse on eating, as in at the time of eating a meal, and there's no relationship with nighttime symptoms nor any relief with antacids. So that's the way to be thinking about the two. As a little side note, when you're thinking about differentials for an epigastric pain, for example, if you're in an OSCE, it's probably not worth immediately jumping to trying to define the ulcer. Peptic ulcer disease itself is a differential. And if you want to be savvy and say, well, I think it's peptic ulcer disease and my suspicion would be this type because of these reasons, then fine. But you don't have to pigeonhole yourself. You can sit with a diagnosis of peptic ulcer disease. So when you're investigating these patients, the most important thing to do is an OGD. So that's a upper GI endoscopy. And then also you want to be thinking about your H. pylori testing as per the previous slide. So that might be with your breath testing or stool antigen testing. And that will then steer your management. So if H. pylori is found to be present, you want to implement your triple therapy, as we mentioned, and you also need to review their medications. So you'd be looking for their NSAIDs, their steroids, and it might not be possible to completely stop those medications, but you might be able to either tailor the dose or at least acknowledge the fact that there might be an association. And then in terms of a kind of chronic ulcer, you'd treat it with a PPI such as lansoprazole. So if it's duodenal, it would be 4 weeks, and if it's gastric, 8 weeks. The way I always like to remember that was gastric ulcers are exposed to the greatest concentration of acid, and so they're particularly inflamed, particularly irritated, and they take longer to heal. And so you need to use a prolonged dose of a PPI. So there's a question here. Now, this question won't lend itself very kindly to our polls. So what I'm going to ask you to do is try and answer it as best you can. Try and commit to an answer. I never liked it when people said that to me. It felt easy to do and you never really wanted to. but try your best to at least work through it in your head. So try and name the 5 signs that are shown on the screen, and then try and identify which of the 5 we might associate with gastric cancer. So we'll give a minute or so for this, because it is a double-sided question. Okay, I'll give it 10 or so more seconds. Okay, so the answers are on the screen. So Virchow's node is A, which is an enlarged left supraclavicular lymph node. Acanthosis nigricans is this kind of velvety hyperpigmentation of the skin, typically in body folds and skin creases. So things like the groins and the armpits are particularly at risk. Spider nevi, a collection of small telangiectasia, so dilated blood vessels under the skin. A number of 5 or more is considered pathological, because naturally a lot of people might have 1 or 2 dotted on the body. Pyoderma gangrenosum. So this is a kind of ulcerating, pretty unpleasant looking condition often seen on the legs. And then erythema nodosum. So these are red nodules that are painful and tender on palpation. So if you got those, fab. Now, in terms of which ones we might associate with gastric cancer, the answers are A and B. So these are both signs of fairly advanced disease. It's worth being aware about. You're not expecting for these to be the first sign that you'll detect someone's cancer on. However, as we know in medical exams, you have to kind of be fairly straightforward about what you're thinking. They're gonna give you hints to the right diagnosis, and these might just be those hints. So I've given a little definition for each, hopefully similar to my kind of voicing over of what each one is underpinned by, and also where you might see them. So your Virchow's node is particularly associated with gastric cancer. Acanthosis nigricans is also seen in diabetes. Thankfully, the presentations of the two shouldn't overlap, so you should know which one you're looking at. Spider nevi is associated with chronic liver disease. Pyoderma gangrenosum is commonly seen in IBD. And then on a side note, you might also have RA, so rheumatoid arthritis. And erythema nodosum is not particularly specific. However, IBD is common again, as is sarcoid and streptococcal infection. So it's worth being aware. It's probably one of the more tricky parts of finals revision, the kind of dermatological manifestations. So if you can have a little bit of an idea of those, they might just buy you a mark or two. So gastric cancer is a cancer, of course, of the stomach mucosa. Over 90% of cases are adenocarcinomas, which is predictable. So an adenocarcinoma is a cancer of the glandular tissue and glandular epithelium. And of course, the stomach is known for secreting acid and secreting all sorts as part of its kind of physiological function. And so it makes sense that most of those cells there are glandular cells, and therefore when they turn to cancer, that's the type. Risk factors include being male, H. pylori infection or chronic inflammation, smoking and alcohol. And the symptoms are often very non-specific, so it is worth just being aware of some of those signs that might just point you in the right direction. Dyspepsia, so indigestion and heartburn. Dysphagia, early satiety is a good one. Nausea, vomiting, melena, fatigue, and weight loss are all fairly textbook. On their own, it would be difficult to pick one diagnosis out from the others. However, Virchow's node and acanthosis nigricans do point you in the right direction. And the most important thing to be aware of is the 2-week wait. So if you have a patient that's flagging up as a 2-week wait for suspected gastric cancer, you know that you're going to want to give them an OGD urgently. Be aware of your H. pylori testing. And as with a lot of cancers, be aware of CT staging, trying to basically see at what point this patient is in their journey and how you're going to treat them. The ideal treatment would be with some sort of surgical excision, and you might have pre or post-op chemotherapy with that. A lot of these patients unfortunately present late because of the reasons I've spoken about, and so they might require palliative input to provide them with their best quality of life. An interesting condition about gastritis and dyspepsia is Zollinger-Ellison Syndrome. So this is a neuroendocrine tumor that secretes gastrin in the stomach. And as it sounds, these tumors present with increased levels of gastrin, they secrete increased levels of gastrin. And as a result, you get excessive gastric acid secretion, and therefore these risks features of abnormal ulceration, severe ulceration, and then malabsorptive states as well as a result of that. So it's worth just being aware of, if you have a really kind of intense gastric acid and dyspepsia picture, just be aware of this condition. It can be associated with MEN, multiple endocrine neoplasia, and over 60% are malignant as well. I don't think it's particularly likely you'll be asked to investigate or manage a patient with Zollinger-Ellison syndrome. However, as you might think, given the condition is characterized by high gastrin levels, you can assess their serum gastrin. You can scope them to look at for ulcers. And if you can image the tumor itself, even better, that will give you a more definitive diagnosis. The management is with removal of the tumor definitively, and a high dose of PPI will help in terms of managing their symptoms. Fab, so that's dyspepsia then. So we're going to move on a little bit to dysphagia. So we have a patient, Mr. Reese, who is 49 years old, presents to the GP with difficulty swallowing. Over the last 4 months, it's got progressively worse. It initially was difficult to swallow chewy food and large solid foods. Now he's occasionally regurgitating liquids. It's associated with weight loss and fatigue. He has a long history of heartburn, and he drinks 1 glass of wine with food on a Friday and Saturday, smokes 30 cigarettes a day for as long as he can remember, and he's a postman who works out the house on his feet. So which of the following is the most likely diagnosis? So waiting on a couple more answers. Cool. So we've got a spread of answers between A, B, and C. B was the most popular answer. So B is right. Esophageal cancer is the best or the most likely diagnosis. Now we'll talk through the differentials here with a little summary of which ones, what would make you think of each effectively. I'm not particularly surprised to see Barrett's esophagus being the second most common. And then achalasia, I think, is probably the most reasonable one after that as well. So it's fairly understandable. Now this patient is presenting with weight loss and progressive dysphagia. So anytime you have a patient who has progressive dysphagia, meaning they can eat solids at one time, they then have difficulty with solids, but fine with liquids. And then it gets even worse again to liquids, or problem when drinking liquids. You need to be worried about cancer. That's kind of symbolizing that there's something blocking the outflow or the transit through from the mouth to the stomach that is getting bigger, because at one point only liquids can go through and soft things, and then even at that point it gets even tighter again, meaning they struggle as well. So progressive dysphagia in a patient who's fatigued with weight loss, you need to be aware of their risk of cancer. Barrett's esophagus is a really closely linked condition to esophageal cancer. Specifically, it's linked to adenocarcinoma. So Barrett's esophagus is a pre-malignant condition that is associated with a long history of GORD or dyspepsia. And it's effectively this metaplasia in which you have the change of epithelium within the bottom of the esophagus. Now, fair enough, it sounds like that quite closely applies to our patient. However, we're looking for the most likely diagnosis and therefore the best answer. And whilst Barrett's esophagus may be true, it actually sounds like it's gone beyond that point. This patient now is having difficulty swallowing, he's fatigued, and he's got weight loss. So he may have had Barrett's esophagus at one point, but we're now much more worried about cancer. When you're trying to spot achalasia, the achalasia is a problem with the tone of the lower esophageal sphincter. And so what we're thinking about in these patients is a history of dysphagia to solids and liquids of fairly similar degree at the same point in time. So unlike cancer, where you start having difficulty with solid food and then it gets worse, they're both pretty bad and it doesn't change over time. And the two foods struggle equally, if you like. Pharyngeal pouch. So pharyngeal pouch is much less commonly talked about in exam settings. However, it's really important to just have a 1 or 2 line summary of in your head. So you're suspecting a pharyngeal pouch in patients who have dysphagia, who have offensive smelling breath, and sometimes they'll report a gurgle in their throat, especially on palpation. So anyone with unpleasant breath and a gurgle, think about a pharyngeal pouch. And then MS is a very valid cause of dysphagia. However, in this case, there's absolutely no discussion of a neurological deficit, of a family history of MS, or anything of the sorts. If you're having patients who have problems with their limbs, or they have a problem with their eyes that sounds like optic neuritis, you may well think about MS, or you may well even think about motor neuron disease or any of the other neuromuscular diseases. But in this patient's case, no, it doesn't quite sound the same. So we diagnosed this gentleman with esophageal cancer. Now, which of the two conditions, which of the two cases, excuse me, A or B, is most suggestive of a squamous cell carcinoma of the esophagus, as a little add-on, as opposed to an adenocarcinoma of the esophagus? Okay, so I'm just going to try and launch a poll now. Just dip out very quickly. There you go. Hopefully that's working for you guys. I'll just return it to the slide. There you go. So A or B should be the only ones used, hopefully. Fab, we got loads of votes flying in. 1 or 2, we'll leave time for 1 or 2 extras. Okay. So the majority have gone for A, and then we've got 1 or 2 cases of B. So the answer is in fact A. So that was very well done. Now there are a few buzzwords that you want to be looking out for when differentiating the two, as I'll pop up here. So squamous cell carcinoma tends to present in older patients, people who have Black ethnicity or Afro-Caribbean heritage are at particularly increased risk. If you see the word smoking, it's much more strongly associated with squamous cell carcinoma, as is excessive alcohol consumption. And the real giveaway is the fact that the cancer is in the middle third of the esophagus. So the way I always like to think about it is when you're thinking about the esophagus, it has a kind of transitioning epithelium. At the top, you have a very kind of squamous cell heavy epithelium. In the middle, it's slightly more mixed, but leaning towards squamous cell once again. And at the bottom, it's very much more glandular. And you might expect that, thinking that it's effectively a continuation of the stomach's epithelium upwards. And so the stomach's very glandular, so you might expect some of those cells to be present at the bottom of the esophagus. So as I said, they're the main buzzwords for squamous cell carcinoma. In terms of an adenocarcinoma, it's much more common in younger people. So we're typically thinking about 50 to 60 years old, squamous cell being about 60 to 70. It's more common in white patients, in those who are obese and those with long-standing dyspepsia, so Barrett's or GORD. And as I said, it's more common in the lower third of the esophagus as well. So I hope that all makes sense. So just to touch upon esophageal cancer then. So there are two types we've talked about. The middle third is your squamous cell carcinoma, and your adenocarcinoma seen in the lower third. And your risk factors are fairly uniform over the two types. However, it is worth thinking about which one points to which diagnosis. Progressive dysphagia with weight loss, fatigue, or dyspepsia are the buzzwords. If you have a patient with progressive dysphagia, query cancer. And you need to hopefully refer them under the 2-week wait, which you'd expect them to meet, especially in an exam question. Barium swallow might be helpful to visualize for any kind of structural problems. And your CT for staging will be helpful in terms of managing these patients as well. Esophageal cancer has a really poor prognosis, I think, because it presents quite late often, and it's just particularly an unpleasant cancer. So we did mention Barrett's esophagus, so we'll just quickly touch upon that as well. I think this box should hopefully give you the sort of high yield bits and bobs about Barrett's that you shouldn't have to go too much deeper with. It's a pre-malignant condition, so we're worried that as a consequence of Barrett's esophagus, patients may develop cancer. It's a metaplastic disease, meaning you have healthy squamous replaced with columnar cells, but it's not dysplastic, meaning they're not differentiated to a different degree, nor clearly malignant. And its diagnosis is with OGD and histological review. As I said, it predisposes to adenocarcinoma, and patients are managed with long-term PPIs and with surveillance as well. It's worth mentioning, it's a bit of a PassMed favorite as well. It's worth mentioning that these patients have metaplasia, as I've said, so they're treated with PPIs and surveillance. If a patient was found to have dysplasia, meaning you have abnormal or unhealthy cells replacing the squamous epithelium, you would then expect them to have endoscopic therapies, such as resection or cautery or something similar. So that's a small differentiation that also might just buy you a mark or two. But to be honest, I think it's more likely to help with your revision on PassMed than come up in the final exams. Okay, and so at this point, I will hand over to Oscar. If anyone has any questions about what I've talked about so far, feel free to ask away, or if you want to hold them till the end, that's fine as well.
So we'll have a 2-sec break whilst we change screens. Is that up, Mike?
Yep, you're good to go, mate.
What time is it? We may as well just keep going if everyone's okay with that, as long as people don't want a break. If anyone would particularly like a break, put it in the chat and I will stop. So now we're going to talk about some more of the HPV causes. So the first case is about jaundice. So you've got a 73-year-old man who presents to A&E with jaundice. He's got a yellow tinge to his skin and eyes that started 2 days ago. He denies abdominal pain, but his urine's darker than usual. He's got a history of diabetes, hypertension, and an MI, and he takes metformin, aspirin, and Rampril. He's an ex-smoker, and he likes to have a drink with his evening meals. So, first question. think Mike will be able to share the poll. Given the history, where is the most likely location of the pathology? So I'll give you a couple secs to do this. Wait a couple more seconds. Okay. So the majority have gone for E, which is the correct answer. So what this case in this history was getting at is that it was painless jaundice. So the guy denied any abdominal pain. And basically, if you ever get painless jaundice, it's pancreatic cancer till proved otherwise. There's nothing really about any blood disorders or anything to do with the liver. Someone put common bile duct stone, which again, you're right, would cause jaundice, but you might expect pain, although it can be without pain. But again, still older guy, painless jaundice, it's got to be a pancreatic tumor. So if it was a tail of the pancreas tumor, you wouldn't necessarily get jaundice because it wouldn't be blocking any of the ducts. So for example, in the head, obviously it then drains through the ampulla retrata into the duodenum. And then that's when, if you get a tumor there, that's where it blocks the duct and then causes the jaundice. So that's why E is the right answer. So well done if you got that. So just going to quickly go across jaundice. Again, best way to split it up: pre-hepatic, hepatic, post-hepatic, and I'm sure most of you do that anyway, so I'm not going to dwell on that. It's worth knowing a little bit about bilirubin metabolism because that does help a little bit. And also probably the key bit is this stercobilin, which this is what gives you the dark color of stools. So some people, when they have like common bile duct stones or pancreatic tumors, they say, oh, well, I've got pale stools. So essentially it's because this compound isn't getting into the stool. Similarly, I'll talk about in a couple of slides time about why you get dark urine as well, because those two clinical features can be quite helpful to distinguish between pre-hepatic and post-hepatic. So next question. 19-year-old girl presents to GP with her mum. Her mum's noticed that her eyes look a bit yellow and she's worried because her grandfather died of pancreatic cancer. The girl's undertaking her A-levels exam and she's tired all the time. She's got no weight loss, no short of breath, no cough, not lightheaded, and no abdominal pain. She's got icterus of sclera and there's no abnormality on abdo examination. What is the most likely diagnosis? So I think Michael share again. A few more seconds. Okay. Fab. So most people went for D, and some people went for B. So D is the right answer. Again, in finals, you will get questions where there's two answers that sound quite right, and in this question, it is B and D that are kind of the ones where you think, oh well, it could be the other, could be one. So D is the right answer. Gilbert syndrome. So this condition basically presents in people who are normally fit, healthy, and well, and they get like jaundice in their eyes. Usually, it's never usually bad enough to have skin jaundice, but essentially, it's not iron deficiency anemia. Although it's a good distractor because it says she's tired all the time. with normal iron deficiency anemia, you would not get jaundice. So that is why that one rules it out. But again, you could argue. So yeah, D is the right answer. So yeah, Gilbert syndrome is one of the pre-hepatic causes, probably the more common one. The other common ones are some of the hemolytic anemias. So they're kind of a session in themselves, so I'm not going to go into them. But essentially what happens in your pre-hepatic is excess unconjugated bilirubin builds up faster than the liver can conjugate it for excretion. So that's what causes the yellowing of the skin. It's the unconjugated bilirubin. I put a box with some clinical features there. Again, they might get anemia and weird stuff, but you'd have to have, iron deficiency anemia would never cause it, because you'd need something that is basically destroying the red blood cells to release the bilirubin. Some investigations here. Again, this girl probably would have had an FBC for iron deficiency anemia, but also I think the GP probably would have just said, well, it's Gilbert syndrome and it's essentially benign. And I can't remember what the enzyme is called, but basically it's just a congenital deficiency of one of these enzymes, and it's a harmless condition really. It's usually brought about by things like stress. So that was the other thing in the question, is that the girl was doing her A-levels, so she was a bit stressed. Other things that can bring it on is like sport and stuff like that. I'm just going to flash up some examples of hepatic causes of jaundice. There's absolutely loads of them, so I'm not going to go into any details of them. But again, if you're ever asked in an OSCE about jaundice and stuff, break it down this way. Pre-hepatic, some of the causes include Gilbert's, hemolytic anemia. Hepatic causes, things like cirrhosis, primary biliary cirrhosis, Wilson's disease, just stuff like that. So next question, moving on swiftly. An 80-year-old female presents in SAU with jaundice of unknown cause. She has Alzheimer's disease and lives in a care home. She has a CT abdominal emission that shows a dilated common bile duct, but no obvious lesion or stones are seen. What is the next most appropriate investigation? So have a think about this investigation, about what investigation is the next most appropriate. Remember, she's had a CT. This one might be a bit of a hard one, but I just put it in to highlight a key point, really. Just wait for a few more answers, let you have a think, because it's not an easy one. Again, I don't know if it'll help, but obviously she's presenting with jaundice and she's got Alzheimer's, so we don't know if it's painful or painless, but given her age, you're probably quite worried about a cancer. Okay, that's good. We got quite a lot of answers there, which is good. So D was the right answer, so well done. Some of you did put A, which was the big distractor. Okay, so she's already had a CT and it shows a dilated common bile duct. So if you get something like that, then you're thinking, is there a blockage for it to become dilated? But no obvious lesions or stones are seen, and this can happen with a CT. There might be a common bile duct stone there, or there might be a tumor somewhere that a small one that you might not see on the CT. So the next best answer is MRCP. So the difference between MRCP and ERCP, MRCP is really good for imaging the bile ducts, whereas ERCP, you do get imaging from it, but it's more used therapeutically, so to treat a common bile duct stone. So I think this is quite a good point to highlight the difference between the two. So MRCP, imaging, can't really use to treat. ERCP, you put a scope down, you cannulate the ampulla, and then you inject a dye. So it gives you an image, but also it allows you to remove a stone. Ultrasound scan's not the best answer. MRI liver would also be helpful, but it's not the best answer. And then bloods, she would get them anyway, but it's not the most appropriate. So D. Again, break it down, post-hepatic causes, anything that's going to block the biliary tree, really. So gallstones in the CBD, or Morizi syndrome, which is a bit of a weird one, where you have a stone in the bottom of the gallbladder in something called Hartmann's pouch, and it blocks the CBD from there. And then pancreatic cancer, cholangiocarcinoma, biliary stricture, and then some drugs can cause it as well. And we spoke about the benefit of MRCP versus ERCP. Just a key point to add is the reason why you get the dark urine is because conjugated bilirubin builds up. So some people think that it's the urobilinogen, but that's not true. That is a normal byproduct of the breakdown in the bowel that gets reabsorbed and used again. But with a blockage in the common bile duct, the conjugated bilirubin is not being excreted in your stool, therefore it builds up, and then it's got to go somewhere. So the only place for it to go is to be excreted in urine, given the dark urine. So dark urine, pale stools, always a good thing to remember about post-hepatic causes, and actually some of the hepatic causes can also cause it. So I'm not going to dwell too much on pancreatic cancer. It presents late, often with metastases. The symptoms are very non-specific. They're listed there. One random, probably another bit of a past med one is Courvoisier's law. So jaundice and a palpable gallbladder is unlikely to be gallstones, i.e. it's probably cancer. Important investigations, again, CT for staging. That's always a good one with any cancers. You know, how are you going to work them up? Well, they need a staging scan so you can tell, you know, because the difference with pancreatic cancer management is if it's metastatic, then really they're only going to get palliative care, maybe some chemotherapy, whereas if it's not, then you can give surgery. But again, it's got a pretty poor prognosis. About 5-year survival is about 6%, which is rubbish. A CA19-9 is another good one to remember. It's like a biomarker for pancreatic cancer, and gives a good thing a prognosis of it. But again, it's quite non-specific, so lots of other things can make it raised. For example, if you had like cholecystitis, that would probably put it up. Right. Quickly on cholangiocarcinoma, just because it was on the learning objectives, it's just an adenocarcinoma of the biliary tract. I wouldn't learn about the locations of it really, but maybe know one or two of the risk factors, like PSC is a big one. Maybe viral hepatitis as well, but I'm not going to dwell on that. So next question. 39-year-old woman presents with upper abdominal pain that radiates to her back and sides. She's vomited twice. She doesn't drink alcohol and has no past medical history. Her BMI is 37. On examination, she's sweaty and clammy. She has epigastric tenderness and guarding. On ultrasound scan, she has gallstones in her gallbladder. So the question is, which of these criteria are needed for the diagnosis of acute pancreatitis? So the diagnosis of acute pancreatitis. Just give it a few more seconds. Fab. So most people got it correct. Whoops, sorry. It was raised serum amylase is the right answer. So I'll go on to the next slide why that's the right answer. Again, she's presenting with upper abdominal pain. And to be honest, it's a bit of a non-specific history, but that's kind of what acute pancreatitis can be like. So there's obviously a really wide differential for this, but the question's actually nothing to do with, sorry, the question is nothing to do with the actual case. So yeah, raised serum amylase. So for acute pancreatitis, you need 2 out of these 3 criteria. First one's clinical, so it's upper abdominal pain. Usually it's quite severe and radiates through to the back. The patients will present like quite unwell, sometimes nausea, vomiting. Cullen's and Gray Turner's sign are really, really rare. But so Cullen's is the bruising around the umbilicus, so periumbilical bruising, and then Gray Turner's sign is the flank pain bruising. And you usually get these like with quite severe pancreatitis. Next one is raised serum amylase or lipase, and it needs to be 3 times the upper limit of normal. Again, there's lots of things that can put amylase up. So, you know, it can be a tricky diagnosis. And then also there's imaging features. So CT, MRI, ultrasound scan, and I've listed some of them there. But probably the easiest test that most people that go to A&E will get is a serum amylase, and actually because it can be non-specific with just abdominal pain, most people presenting with abdominal pain will get at least an amylase. So it's worth thinking about, in an OSCE, if you've got someone with abdominal pain and they say, well, what investigations do you want to do? It's quite an easy one. So causes of acute pancreatitis, I'm sure you've all seen it. I get smashed. I'm not going to go through all of them. Just want to really highlight that gallstones and alcohol are the most common. So really, if anyone ever asks you what the cause is, it's more likely to be one of those two. And from the history, the lady, I put in a few risk factors for gallstones, and she had gallstones on her ultrasound scan. So it's fat, fertile, female, 40 and fair. So that's quite a good mnemonic to remember some of the risk factors for gallstones. Fine. Oh, actually, on one side note, I just want to add, ERCP can cause acute pancreatitis. So unfortunately, sometimes people can come in with a common bile duct stone, then you do an ERCP to treat it, but then you give them pancreatitis. So I suppose that's quite one of the more interesting ones to think about. Severity score for it, again, I don't think they would ask you in this in the exam, but it's kind of worth knowing about, really. And again, the acronym for it is pancreas. I'm not going to run through all of them, but with this score, then people will get the score about after 48 hours of admission, and then it'll decide whether they go to ITU or not, because it kind of risk stratifies whether they're going to get some of the complications that are shown on the right hand side. So necrotizing pancreatitis is the big one. If a patient gets this, then mortality is a lot higher than just bog standard pancreatitis. Pseudocysts are usually quite benign, but they can have drainage. And then you can get acute respiratory distress syndrome and DIC. So it's worth just knowing a few of the complications. Again, the most common thing they're going to ask you about this is about like the diagnosis, with raised amylase and upper abdominal pain. Question 11. 50-year-old male presents to GP with epigastric pain. It's relieved when he sits forward. It's episodic, but he can't think of anything that's triggering it. He's a non-smoker, but he drinks a bottle of whiskey every evening. On the review of symptoms, the patient's been having trouble with his bowels. His stools become quite smelly and sometimes difficult to flush away. What is the most likely diagnosis? Again, in GP, you might be considering a lot of these as your differential diagnosis, but we're looking for what is the most likely diagnosis. We'll give a few more seconds, get a few more answers. Doing well so far. That'll do. Well done, guys. So well done. C is the right answer, and most of you went for that. It probably helps that I am talking about the pancreas, so it's a bit of a giveaway. But yeah, so chronic pancreatitis is the right answer. I think the big giveaway with this one is the big drinking history and the stools becoming quite smelly and difficult to flush away. So that's kind of textbook. It's called steatorrhea, so that's textbook of chronic pancreatitis. Again, with someone with abdominal pain and bowel problems in general, the A, B, even E, you could probably get away with as a differential, just about. But yeah, C is the best answer. So again, quickly about chronic pancreatitis, most people have an alcohol excess history, so they're usually big drinkers or been drinking for many years. You can get family history. Weight loss, bloating, fatty, smelly stools that don't flush away, or steatorrhea, they're all big symptoms for it, okay? So if you hear something like that, then it could be chronic pancreatitis. And so what happens in chronic pancreatitis is you get exocrine insufficiency. So lipase and amylase isn't secreted because the tissue in the pancreas basically dies. So that's why you get the fatty, smelly stools. And then you also can get endocrine insufficiency. So the big one would be if the pancreas stops secreting insulin, you can get diabetes, and it's called type 3 diabetes. I don't think anything more needs to be said about that, really. It's probably not a big exam topic, but one worth knowing about. So Case 6. So with this one, I just want you guys to have a look at the LFTs. So it's a 55-year-old patient that's got hypertension, normally fitting well. He drinks 5 cans of K cider every evening. So I want you to try and interpret the liver function tests. So I'll give a little bit, I know this thing's gone up, but I'll give you a few more seconds just to look at the LFTs and think what's abnormal there, because that's going to inform the next question. Again, for those of you that don't know, K cider is like a strong cider, so he's got an alcohol history. So I will move on in a second. Just make sure you've all had a go interpreting them. So the question is, what pattern of liver damage is shown in the patient's LFT? So this question is about interpreting liver function tests. So sometimes in the exam, what they'll give you is they'll give you a kind of a history, and then they'll give you some bloods. So sometimes it's like an FBC, but there's no reason why they couldn't give you LFTs. So what pattern of damage is shown here? LFTs can be quite difficult, so I will go through some pointers that I use to interpret them, which really helped me. So we'll give it a few more seconds. Okay. So actually, well done to the one person who got it. Oh wait, no, sorry. Well done to the 5 people who got it right, sorry. I got the wrong answer. B is the right answer, sorry. So essentially, what the liver function test showed, I can't remember if I flashed them up. No, I didn't. Sorry, we'll go back. So the ALT and AST are marginally raised. The ALP is raised, as is the gamma GT. The bilirubin's normal. Albumin and prothrombin time are both abnormal quite severely. Okay, so it's a bit of a mixed bag. But those of you who put B are right, and I will explain why now. So I'll flash all these up and then talk about them. So ALT and AST, they are markers of hepatocellular injury, so injury to the hepatocytes. Now, what usually happens is if you get an acute kind of picture, you get a rapidly raised one, so it's quite a lot higher. In this guy, they were kind of hovering around a little bit raised and probably nothing to shout home about. ALP is marker of cholestasis, but it's produced by lots and lots of things, so liver, bone and bile duct all produce it as well. So that's why it can be a good one to look at for a cholestatic picture, but just be aware, like bone mets and vitamin D deficiency can cause it to be raised. Gamma GT is another marker of cholestasis, or more specifically biliary damage, but this can be increased in alcohol abuse. So this man had a raised one, but that's probably not surprising. So in some patients who will be totally normally fit and well, they might have an isolated gamma GT rise, and it might just be caused because they drink a lot of alcohol. Again, bilirubin can be raised in or is raised in a cholestatic picture as well. So it's quite a nice way to think about it. ALT, AST, the liver, ALP, gamma GT, and bilirubin, the bile ducts, and then albumin and prothrombin time, as well as INR and glucose, are more for the synthetic function of the liver. So I'll just go back again. So the reason it's not a cholestatic picture is because the person doesn't have a raised bilirubin firstly, and then the other two aren't really much to shout home about. And given that gamma GT can be raised by other things, as can ALP, it's not the best one. The two acute liver patterns, paracetamol overdose and viral hepatitis, you'd expect a much bigger rise in ALT and AST. And again, it's not a normal variant because his prothrombin time and his albumin are deranged. So I hope that goes a little bit of a way. So here we go. That explains it a bit better. So I'd probably just say, remember when you're interpreting it, albumin and prothrombin. So if albumin's low and prothrombin's raised, it says that it's impaired sympathetic function, and you get that with chronic liver disease. So that's what the patient has from drinking loads of cider over many years. With the other ones in chronic liver disease, you can get all sorts of pictures, which is why sometimes it's more helpful to think of them broadly than, you know, trying to look at it and say, oh, well, the ALT has risen by three times the amount. It's just look at it broadly. So another question about chronic liver disease: which of these clotting factors are impaired in chronic liver disease? Things about like clotting factors and the coagulation cascade is one of those things that you always learn for finals, and then it never ever comes up. It's a bit of a ridiculous one, but you'd probably kick yourself if you didn't learn it, because a question like this is probably quite an easy 1 mark for them to put in. So we'll give you a few more seconds. We're getting towards the end as well now, guys, so well done. Won't be too much longer. Obviously, upper GI is quite a big topic, so there's quite a lot to cover. Fab, so we'll share this now. So well done to those of you who got it right. You can tell people have been prepping for finals. So the right answer is B. So impaired in chronic liver disease, it's also helpfully the same factors that warfarin inhibits. So it's very much worth learning it for that anyway. So factor 2, factor 7, factor 9, and factor 10. Factor 10A is inhibited by DOACs, so that's why you might know that one. Factors 2, 9A, 10A, and 11A are inhibited by heparin and enoxaparin, and basically, well, heparin and enoxaparin inhibit antithrombin 3, which in turn inhibits these factors. Prothrombin is an important one in the coagulation cascade, but it's not the best answer. And then the ones at the bottom, I just put 4 random ones together. So well done to those who put B. It is worth learning the coagulation cascade, I think, but again, for example, if you were 2 weeks before final, I'd say don't bother, but it might get you a mark. Just quickly on liver cirrhosis, again, like alcoholic liver disease and liver disease in general is a big topic, and actually something that doesn't really come up that often in finals. But one thing you might get is to do with the complications, which is of, you know, chronic liver disease and liver cirrhosis. So obviously ascites, splenomegaly. In liver cirrhosis, you don't usually get hepatomegaly. You usually get a cirrhotic liver, which is shrunken. So just something to bear in mind. Hepatic encephalopathy, the Whitehaven criteria enable you to classify how bad it is, and then they get a liver flap. So that's why you put their hands up, and then it's like that. We've talked about the reduced sympathetic function, so that's what you're measuring with your prothrombin time and your albumin. So hypoalbuminemia, and you get an increased INR, thrombocytopenia, people get bruising, stuff like that. There's other weird ones like hepatorenal syndrome and cardiorenal syndrome. I think I wouldn't go learning about them, but the thing to remember is if you throw someone's albumin off, then essentially their blood's not going to regulate its blood volume as well, because albumin's a big part of what makes up the constituents of blood. And then basically what happens is when the liver goes off, then your heart and the kidneys are more likely to as well. Child Pew scores, definitely something to know, maybe not to learn what each points give you, but to know what's in it. So encephalopathy, ascites, bilirubin, albumin, prothrombin time, they're all basically important to classify the severity of the cirrhosis, which is why albumin and prothrombin would be off in cirrhosis or chronic liver disease. So later that year, Mr. George is admitted to hospital with ascites. He continues to drink despite the GP's and hospital's advice. Which combinations of medicine are appropriate to prescribe on his admission? So I put this question in because I think it's probably quite a good finals one, because they like things about medications and mechanisms of actions and stuff like that. And again, just remembering back to the case, the guy is an alcoholic with chronic liver disease, and he's now admitted to hospital with ascites. Okay, so this might be a little bit of a hard question, but just have a think what you'd put or what you'd prescribe for him on his admission. a helpful way sometimes is to just rule out what you know is wrong. So that's what I probably did for finals the most, is if you can get down to 2 answers and take a 50-50, you know, you can always get rid of 2 straight away. And then sometimes, unfortunately, you just got to take a guess and hope you're lucky. But I will explain which one's the right answer in a minute. If you've done psychiatry this year as well, then this one of the psychiatry cases, I think if they're the same, might be able to help you with this case. So we'll give it a few more seconds. I know I've left a little bit longer on this one. Okay. So the correct answer is B. So well done to the majority who put that. I'm quite impressed, actually. It's quite a good one. I don't think I would have known that. So what I'll do is go through the wrong answers. Parvlex or acetylcysteine is for paracetamol overdose, so straight away you can get rid of that. He doesn't have paracetamol overdose. Lactulose is an osmotic laxative. Sometimes it's used in hepatic encephalopathy, and what it does is it stops ammonia being absorbed in the gut, which is what causes hepatic encephalopathy. Again, that's the wrong answer. There's nothing about him being encephalopic. Ceftriaxone is cephalosporin. It can be used in spontaneous bacterial peritonitis, which can be a byproduct of ascites, but again, there's nothing to say that he's really unwell with SBP. Acamprosate is a drug that's used to reduce cravings in alcohol withdrawal and rehabilitation, as is disulfiram, which is basically a drug which causes like a flushing and hangover like reaction. So you use it in rehabilitation of people who are trying to, you know, go into rehab and stop, trying to get them to stop drinking alcohol. Diazepam and lorazepam are both benzodiazepines. So as you can see, I'll just go back for a sec. A, you get rid of straight away. C is not a bad answer, but it's not the most appropriate, for which I'll explain in a minute. D is 2 benzodiazepines, so I don't think you'd want to prescribe that. And again, E is not the best answer either. So the reason why the 2 best answers up there are Pabrinex and chlorodiazepoxide, or Librium. So Pabrinex is basically a solution that you might see people on, and it's got vitamins B and C in it, and it prevents Wernicke-Korsakoff syndrome, which is vitamin B1 deficiency. So people who are drinkers, if they stop drinking, they can basically get this Wernicke-Korsakoff syndrome because they're deficient, and it's a combination of the alcohol and also usually they're malnourished and already quite unwell. But this is one worth knowing. So the triad is confusion, ataxia, and not ophthalmoplegia. So, and if you don't treat it, you get Korsakoff psychosis, which is irreversible antegrade amnesia with confabulation, which is a mouthful, but essentially they get like, they don't remember things, and then they basically just make up these like stories. So like you'll ask them something and they'll give you something like a credible answer, but it won't be like anything to do with what has actually happened to them. So they might be like, oh yeah, I was in the shops yesterday and doing this, and they'll give you like a really coherent story, but actually they've been in hospital for 2 months with ascites and they're really unwell. Chlorodiazepoxide, or Librium, is the main benzodiazepine used to prevent withdrawal. So it's similar to diazepam and lorazepam, but this is what they usually use. And the reason why these 2 are the best answer is because this guy's come in after being an alcoholic. And if you don't prescribe Pabrinex and chlorodiazepoxide or Librium, then what will happen is the patient will get withdrawal from alcohol, because obviously in hospital they're not drinking. So it's probably a good thing to remember, you know, even as an F1, if someone's got a significant alcohol history, you really, really need to prescribe these, because otherwise they're going to withdraw, you know, they could have a seizure, or they're going to just feel really unwell. Delirium tremens is another thing to remember. You get disorientation, agitation, hallucinations, and that's after stopping alcohol. So this case was all about alcohol withdrawal, and Pabrinex and chlorodiazepoxide is something you really want to prescribe. Just to finish off, hepatocellular carcinoma, common primary liver tumor. However, remember that lots of cancers metastasize to the liver, like colorectal cancer. So actually, hepatocellular carcinoma is not that common. Probably liver mets to the liver mets are probably a lot more common, but HCC can be caused by any any liver disease in general, really. But these are the main ones: hepatitis. And often patients with hepatitis will go on ultrasound surveillance, where they'll have like a scan every year, because essentially they want to try and catch the hepatocellular carcinoma easy. Another good biomarker, AFP, just a buzz one. And again, you can do any of the normal exams, investigations with a liver biopsy for definitive diagnosis. Obviously, me and Mike covered a lot today, but it's worth probably knowing about some of these ones. Viral hepatitis, so hepatitis B and C, they're worth having a little look at. Don't go mad, but it might be worth being able to interpret a hepatitis B screen. As with non-alcoholic fatty liver disease, just know about metabolic syndrome. The other ones are interesting, don't usually come up, but there's no reason why they couldn't. But again, look at common things first, you know, and then if you learn anything else, it's a bit of a bonus. So that is everything. Some good resources there. Thanks for listening. Does anyone have any questions for me or Mike about anything that we've gone over, or actually anything in general? We're happy to answer. We'll stay on for a minute anyway, but thanks for listening, everyone. We hope the questions were beneficial. Again, in finals, you might get questions that are, you know, where you can get down to a 50-50, but just go with your gut. That's what I'd say.
Thank you. And please just I've sent the link to the Survey Monkey, so just fill it in so you can get access to the slides as well, and it's very useful.
As I said at the start, we've written some end of session questions as well, which Ash will send to you guys. So